Thank you.
Yep.
Okay, I think we're ready to start. Thank you very much, Mr. IT person. Good morning, everybody. Thank you for making your way to this room, which I know wasn't particularly easy to find. We're here for a wonderful paper session on organizational learning, and I think you'll find that the papers fit together really beautifully. So we have 4 papers in a discussion on the processes and performance related to organizational learning. But allow me just to take a couple of minutes to set the stage so we're all on the same page with respect to what is organizational learning and what are we hoping to do today. So organizational learning has been defined as the processes by which outcomes such as adaptation to change, greater understanding, or improved performance in groups and organizations can be achieved. So it is a process, and it is a collective process as distinct from individual learning. A relatively recent publication, Best Care at Lower Cost by the Institute of Medicine, gave us this way of thinking about the urgent need for learning in healthcare, the healthcare system and healthcare organizations. So at every stage of the process, we are missing information, wasting information, and as a result, the patient care experience is not as good as it otherwise could be. And then the big question, and the question that we'll get at today in our session, is how do you promote learning in healthcare organizations and in healthcare systems? So combining a series of studies, I suggest that productively adapting to complex, hazardous, changing organizational landscapes like the ones we have in healthcare to absorb and act on exponentially increasing quantities of clinical information, which is getting bigger and bigger by the day, to rein in cost and to continuously improve delivery, systems, policies, and processes. Healthcare facilities have to become what's been originally called learning organizations, and now we're focusing on learning healthcare systems. So the set of papers that we have this morning are going to allow us to address this in beautiful ways. I'm not going to spend too much time on this because I know Pat's going to bring the work all together, but suffice it to say we have a variety of methods. The learning objectives are all focused on improvement and innovation, various impetus for learning coming from different places, and we'll talk about a variety of antecedents which organizations can take back to try to enhance learning. So let me just introduce our speakers. I'll go through them each and then let them take off from here. So Yuna is going to present a paper on fostering implementation of staff's creative ideas to improve patient healthcare experiences. And I just want to congratulate you and your co-authors because it's the best paper for our division of healthcare management. Yuna is an assistant professor of health policy and management at Columbia University's Mailman School of Public Health. Next, we'll hear from Olivia Jung. She's going to present for co-authors on perceived organizational support for learning and contribution to improvement by frontline staff. She's currently an analyst with Apt Associates. Michael Ann Kyle is going to present a paper on processes underlying team formation in primary care, a qualitative study. She is an ICU nurse as well as a PhD student at Harvard University's PhD program in health policy and at the Harvard Business School. And then finally, Dori will present a paper on leveraging learning, motivation, and resources to improve primary care for high-needs patients. She's currently a PhD candidate in the PhD program in Health Services, Organizations, and Policy at the University of Michigan School of Public Health. And then Pat, as I said, Pat Satterstrom will bring it all together as our discussant. She's currently an assistant professor at the NYU Wagner Graduate School of Public Service. She's also an affiliate with the Management and Organizations Department at NYU Stern School of Business. So, we'll try and get you up and going.
Is there a way to... Sorry. Back on the... Okay, thank you. There you go. Oh, is this It's a PDF. Like a full screen view.
don't. Oh, we need our handy dandy IT guy.
Yeah. It's usually under view. Enter full screen. Thank you, sorry. Thanks so much. Great. So thank you so much, Sarah, for the introduction and for the IT support. Good morning, everyone. I'm really delighted to be here and to have this opportunity to present my work on fostering implementation of staff's creative ideas to improve patient care experiences. As Sarah mentioned, I've been at the Columbia Mailman School of Public Health for a grand total of 1 week so far, but this work represents research undertaken at the Yale School of Public Health with my mentors and co-authors, Paul Cleary and Ingrid Nembhard. And I'm delighted to speak on behalf of Paul and Ingrid that we are so honoured and delighted to receive this award. So to set the stage for this work, many aspects of US healthcare benefit from innovation, which is defined as ideas, practices, policies, or technologies that are new to the context. Now, when we think of healthcare innovation, we may think of new innovations in biotech or technologies, but that's just not the whole story. Innovations in quality improvement or enhancing patient care experiences are important too, and they are often organisational or interpersonal in nature. For example, little tweaks at the interface of healthcare delivery, words and deeds that show respect and empathy for the patient, or little tweaks that show that ideas that are simple but profound, but that make all the difference to the patient. Now, creativity is defined as the generation of novel and useful ideas, and it's the starting point for innovation. It's a thriving field of study in management and organisational behaviour. And given that a big question in healthcare right now is how do we discover new ideas to improve performance, creativity may be a useful concept for quality improvement. Now, right now, many healthcare organisations encourage their staff to generate creative ideas to improve patient care experiences. We know of innovation tournaments, hackathons, staff-led QI teams, executive rounding, all examples of dedicated, concerted effort to solicit staff creativity, and initiatives that seem to resemble initiatives that we might recall seeing in more traditionally creative organisations, such as Pixar and Google. So the issue for us is that little is known about creativity in healthcare organisations, but we might expect that creativity poses tension in this setting. So we know that in healthcare, there is a culture of standardisation and risk reduction. We like checklists and clinical pathways, and we also know that there's a professional hierarchy where the right to speak up comes with experience and status. So given that we have this open question about creativity in healthcare, I set about addressing 3 research objectives. First of all, to examine the impact of implementation of creative ideas on patient care experiences, which was really the first order question. Does creativity matter in this context to outcomes that we care about? Next, to examine the relationship between idea creativity and implementation, and finally, moderators of this relationship. I drew on organisational theory to generate a set of hypotheses. I first hypothesised that the implementation of staff's creative ideas is positively associated with better patient care experiences because staff customise care to individual patients' needs and preferences, and they also have unique access to information on work processes and problems. But I also expect that more creative ideas are less likely to be implemented because healthcare staff have to balance the need to protect patient safety with pursuing things of unknown effectiveness. And then finally, I asked, are there any characteristics of the person who is proposing the divergent change that can make a difference in this relationship? So I hypothesized that individuals that had the characteristics of more collaborative relationships, a longer organizational tenure, and a higher network centrality may serve as legitimizing forces to disrupt the relationship between idea creativity and implementation in a positive way. I addressed and tested these hypotheses using a longitudinal mixed method study I partnered with 12 federally qualified community health centres located in one system in one state. And importantly, these CHCs were involved in an improvement initiative from September 2013 to March 2015, where healthcare teams in every one of the CHCs met monthly to generate, debate, and implement their best ideas to improve patient care experiences. And in these QI teams, there were physicians, nurses, medical assistants, and behavioural health providers. In my analysis, I analysed 220 improvement ideas that were generated by the 72 improvement team members that were associated with the 12 CHCs, and I also analysed data associated with 2,201 patients who were cared for by these individuals. I brought together 4 disparate sources of data for this study. First of all, a patient care experiences survey. So many of us in the room are familiar with the Consumer Assessment of Healthcare Providers and Systems, or CAP survey. This was administered to a random sample of patients at the end of the study period. Next, I analysed 216 sets of improvement team meeting transcripts. So these were meeting minutes where the discussions, the action items, and who said what were dictated verbatim. I analysed these transcripts and extracted out 220 ideas. I then followed these ideas over the course of their life cycle to see what happened to them in terms of implementation outcome. The third source of data was a staff work experiences survey, which was part of a larger study on care coordination, and this was administered to all healthcare staff in the organisation, including the 72 improvement team members in my study. And then also, as part of this care coordination study, all healthcare team members wore these wearable sociometric sensors, and you can see them being worn by our staff in these photos. And these sensors resemble ID badges, and they contain 4 different kinds of sensors that can detect interaction and face-to-face communication patterns between those who are wearing the sensors, and they've been used in a variety of organisational settings. So to step through the first component of my analysis that looked at the relationship between the implementation of creative ideas and patient care experiences, I used a series of multivariate mixed models. The dependent variable in these analyses was patient care experiences, and I measured this in 2 different ways. The independent variable was a creativity-related variable, and this took several steps to generate, so let me just briefly walk through them. I first assembled a panel of 5 experts in quality improvement who were healthcare administrators. And these experts independently rated the 220 ideas for level of novelty out of 5 and level of usefulness out of 5. I then multiplied those scores together to generate a creativity score, which is a gold standard assessment method for creativity used in the OB and creativity research literature. I then averaged across the 5 raters, and I had a moderately high inter-rater reliability of 0.79. To create a centre level variable, I then counted the number of high creativity implemented ideas per centre. And then, because this is a CAPS analysis of sorts, I included a range of patient and centre level covariates, and I also included an organisational culture level covariate, as well as a number of ideas that are generated per site. And in support of my initial hypothesis, I found that the implementation of creative ideas was positively associated with better patient care experiences. And this was for patient care experiences measured in 2 different ways. The second component of my analysis looked at this relationship between idea creativity and implementation, as well as the moderators, and I used a series of Cox proportional hazards models to assess these hypotheses. The dependent variable in these analyses was idea implementation. The independent variable was creativity, but this time at the level of the idea. The moderating variables, which I used in interaction terms, were collaboration, which was sourced from the meeting transcripts, organisational tenure, which was sourced from the staff survey, network centrality, and we used the gold standard measure of network centrality between the centrality from the sociometric sensors. And we include covariates at the level of the staff and the centre. I'm just going to briefly highlight the results here, but what we found was that all of our hypotheses were supported. Idea creativity was negatively associated with idea implementation. So in other words, more creative ideas were less likely to be implemented. but we did find that there were these three characteristics of the person who was proposing the divergent idea that seemed to elevate the likelihood of idea implementation for the same type of idea. And those were more collaborative relationships, a longer organizational tenure, and a higher network centrality. Overall, we should acknowledge that there are a number of limitations with this study. First of all, we're not concluding anything causal here, nor are we specifying if any one idea had an impact on patient care experience. We also acknowledge that these results may not generalize to all primary care clinics or other kinds of healthcare organizations. And then finally, we really focused on the creativity of the idea itself as opposed to aspects of the environment or the context. So there are other aspects that we didn't include that are often included in implementation science studies. Overall, we'd like to conclude here by really focusing on the two main takeaways of this study. First of all, we were really intrigued by what we saw as this paradox of creative idea implementation in healthcare. It seems that creative idea implementation is associated with an outcome that we really care about, but more creative ideas are less likely to be implemented. So is there anything that can veer this ship off course? So we seem to find that there were these three characteristics that not only elevated the likelihood of idea implementation for these creative ideas, but also seemed to signal an embeddedness within the organization that may serve as a legitimizing force in these efforts to improve creativity for quality improvement. We think that these results have implications for organizations research. We think that this study shows that there's some value, but also some challenges of creative implementation in healthcare settings. We think that healthcare offers a rich and really intriguing setting for creativity researchers. For health services researchers, we'd like to shine a light on the importance of the idea itself and the creativity of the idea itself, which isn't currently explored in prevailing implementation science frameworks. And finally, for managers, we think that fostering a climate where creative ideas can be legitimized in order to be implemented may advance quality improvement efforts. So overall, we think this was our first foray into creativity research in this context, and we think that this study suggests that creativity matters not only for organizations, but for healthcare organizations. Thank you so much.
I think what we'll do is take one or two clarifying questions and then hold the main questions for after we let the presenters go. And I'd love to start to ask you, can you give an example of a creative, something that would be considered a creative idea and one that would be less creative?
Sure. So an example of a creative idea that was implemented within these CHCs was something that was really interpersonal. So they found that a lot of the patients that were coming in with wheelchairs felt that they couldn't communicate well with the healthcare team. So one thing that the team suggested was to meet the patients at eye level when they communicated with them, which would change the nature of the interaction, which would promote respect and promote empathy. And that could be a simple tweak that the healthcare team could do in order to facilitate communication. And so that was something that was implemented within the CHCs. An example of an idea that wasn't as creative but was implemented was to create basically a contact list of community partners within the area that they could use to pick up the phone and speak to very quickly. So this was more of a useful idea, but it was considered less novel because it was being used a lot in the primary care organizations within the area.
Okay, thank you. Other clarifying questions for Yuna? Okay, terrific. We'll make
Thanks,
switch.
Sara.
Thank you. Good.
Is that it?
Yeah.
Great. Perfect. Nice. Hi, everyone. Thanks for having me and thanks for being here. I'm really happy to follow Yuna's presentation because I think this project follows really well to what we just learned from Yuna. So I'm going to talk about the organizational support for learning and contribution to improvement by frontline staff. And Andrea, Blasco, and Karim Lakhani are my co-authors and mentors from Harvard for this project. So frontline staff are well positioned to suggest improvement opportunities from their firsthand knowledge of what's working and what's not working. in healthcare, utilizing suggestions from frontline staff, such as clinicians and administrative staff, is associated with improved quality of care, improved processes, and organizational climate that promotes patient safety. But being able to realize improvement through ideas from frontline staff depends on their willingness and ability to contribute or share their ideas. And research shows that being reluctant to talk about problems at work is a common experience for many employees. So factors that encourage or discourage noticing issues and speaking up about them include personality and demographic characteristics, attitude towards organizational functioning, and organizational context. So building on this line on contextual factors, we explore the role of organizational learning on frontline staff engagement with problem solving and speaking up. And as Sara explained before, organizational learning refers to improving organizational processes and performance through integrating new experiences and knowledge. So our research question is, how does frontline staff perception of organizational support for learning relate to their innovating behavior? And we try to answer this question in a healthcare organization conducting an ideation contest in which they solicited staff ideas about how many problems that they're encountering at work and solutions to accompany that problem. So here's our conceptual framework driving the study. I'm going to start explaining from the left side. Extensive organizational research has revealed 3 broad factors or building blocks that are critical for organizational learning. The first is supportive learning environment, which is characterized by psychological safety, appreciation for differences, openness to new ideas, and time for reflection. The second is learning processes and practices that aid generation, collection, interpretation, and dissemination of information. And lastly, leadership that reinforces learning, empowers staff to engage in learning. These 3 building blocks are conceptualized to be independent, discrete, and measured separately, but when they're present together, they synergize and reinforce one another. Moving to the right side, we conceptualize frontline staff engagement with innovation as problem solving and speaking up. Problem solving refers to encountering and observing problems at work and devising appropriate responses that lead to short-term or long-term solutions or fixes. But when this information is not shared, it remains in the influence of sphere of influence of the frontline staff and doesn't reach those with appropriate resources or authority to be able to act on them. So in addition to problem solving, speaking up is an important aspect of frontline innovation that challenges the status quo and leads to enhancement in organizational functioning. Again, here's our conceptual framework, and now I'm going to tell you about our 3 hypotheses which correspond to the 3 building blocks of learning. So first, Detroit and Edmondson show us that frontline employees or frontline staff hold implicit voice theories or taken for granted beliefs that explain why or when speaking up at work might be perceived as risky or inappropriate. These beliefs might include that somebody that's higher in the organizational hierarchy might receive feedback as negative criticism or a sign of disloyalty. And another important aspect of supportive learning environment is time for reflection, as when staff face high volume, pressure, or stress, they are more likely to cut their efforts towards improvement. So we hypothesize that frontline staff perception of supportive learning environment is positively associated with frontline innovation. Next, there are mechanisms that facilitate a continuous flow of information, and these mechanisms include experimenting with new ideas or new ways of working, acquiring knowledge through experts or customers, in this context, patients, monitoring, analyzing performance, and educating and training staff. These mechanisms are shown to be linked to effective learning, and we hypothesize that frontline staff perception of these practices and processes is positively associated with frontline innovation. Next, we know from research and perhaps even personal experiences that organizational learning is greatly influenced by leader behavior. So for example, leaders' actions or words that signal invitation or appreciation for input, coupled with willingness to act on that input, is likely to engender an environment that's characterized as safe and open. So we hypothesize that frontline staff perception of leadership that reinforces learning is positively associated with frontline innovation. Next, I'm going to tell you about the methods that we use to try to test our hypotheses. Our study was a cross-sectional one of an ideation contest held at a cardiology unit of a large academic hospital. The contest drew principles of open or distributed innovation within the boundaries of an organizational setting. The publicized goals of the contest were broadly defined and included seeking ideas to improve patient care, to improve workplace efficiency, and lowering costs of care. All cardiology unit staff were invited to participate in this contest. The contest had several phases, and it began with ideation, in which the staff were again all invited to submit an issue that they're facing at work and a solution that would address it. One person could submit more than one idea, and the first 100 people to participate in the contest received a t-shirt for participating. So the ideation phase was followed by crowd voting, in which the participants were asked to log into an online platform in which all of the ideas were presented in a random order, and the participants were asked to rate each of these submissions on a scale of 1 to 5, with 5 being most excellent and 1 being not as excellent. And no incentives were provided for participating in voting. And crowd voting was followed by awards, in which 4 crowd voting winners won an iPad mini. And for a subset of these ideas, participants were asked to submit a grant application or proposal that included a broader, fully explaining their ideas to management of the cardiology unit. Both ideation and voting phases took place online and required an institutional email login to participate, so we were able to collect all of our data online. And here's a screenshot of the contest. So people could log in through their phones or computer. We try to simplify the contest as much as possible to induce participation. And much like tweeting, people could just log in from their phone or computer and share their ideas that way. And prior to the start of the contest, we administered the short-form learning organizational survey, which was written and validated by our chair, Sara, and her colleagues. The learning organizational survey measures the extent of learning that's occurring in the organization across units and levels of organizational hierarchy. And just in case that there are suspicions that the contest and the survey were related, and to minimize that bias, the two events were sponsored and announced by 2 different groups. So the survey was sponsored by Harvard Business School, whereas the contest was sponsored by the hospital. And 12 months after the contest, we interviewed 16 participants, and we asked them questions like, what made you participate? Is the contest in line with the culture of the unit and the hospital more broadly? And what did you like the most or least about the contest? Our independent variables included learning environment, processes, and leadership, which we drew from the learning organizational survey. And our dependent variable was staff engagement with innovation, which we measured through their participation in the contest. And our control variables included age and whether the respondent was a physician. And we tested our hypotheses using ANOVA, logistic regression, and predicted probabilities. And we examined the significance and the direction of the coefficients to see whether our data supported our hypotheses. So we used ANOVA to compare the survey responses between those that participated and didn't participate in the contest. We used logistic regression to predict the engagement with ideation, as our dependent variable was a binary one. And we used predicted probabilities to examine the marginal effect of perceived support on learning. So the contest concluded with 118 ideas submitted by 60 staff, and 6 of the submissions were awarded grants. 2 received $25K, 4 received $10K to be implemented the following year. The content of the submitted ideas addressed a range of issues, including patient experience, cost of care, workflow, utilization, access, and more. Here's an example of an idea that received many highly rated votes, as well as a grant to be implemented the following year. For this idea, the participant identified the problem as many doctors, nurses, and technicians have no idea how much anything costs. We may make wiser decisions if the prices were communicated. We're out of touch with costs, so we're blindly making decisions and influencing the cost of care. And this person identified the solution as the materials that are both commonly used and those that are more specialized and expensive should have a label with the price on it, so that everyone can get a printout of the receipt or a cost for each procedure or shift. And here are the results from our hypothesis test. The first hypothesis, which predicted a positive relationship between learning environment and ideation, we found support from our data. Participants reacted more positively to items relating to appreciation for new ideas and allowance for mistakes. On the other hand, our second hypothesis that predicted a positive relationship between learning processes and ideation, we found a mixed support from our data. First, with experimentation or tendency to or likelihood to work with new ways of working or new ideas, we found a negative relationship. Our adjusted predictions show that for a person who expressed neutrality in their perceived support had a 10% likelihood of participating, compared to a person who expressed a strong perception had a 4.4% of ideating. On the other hand, we found a positive relationship between knowledge acquisition from experts and patients. That one standard deviation increase was associated with 94% increase in the odds of ideation. And lastly, our third hypothesis in which we predicted a positive relationship between leadership and ideation, we found that our coefficients were in the right direction, in the positive direction, but we didn't find any statistical significance. So in summary, our data supports the hypothesis that supportive learning environment as perceived by frontline staff is associated with increased participation in ideation. And this is in line with previous research demonstrating positive relationship between psychological safety and speaking up. And while these earlier studies relied on self-reported survey measures that are perceptive, our outcome variable uniquely measures actual lived behavior. And next, contrary to our predictions, our findings suggest that the less the organization is distinguished for trying out new ideas or products or services, the more likely the staff are likely to engage in this activity of suggesting explorative ideas. And we speculate that this finding is due to the use of the ideation contest, which was a novel approach for this organization to collect staff suggestions. This physician participant said, "I usually don't get asked what I would do to change a change that would affect across the heart center, but the contest lowered the threshold of doing it that somebody asked." And another contest participant said, "The message that the contest sent was that any of us can participate in innovation or QI projects, and that they or management care about what everybody has to say." In addition, while we predicted a one-directional relationship from perceived support for learning to engagement with innovation, our qualitative findings indicate that the reverse should also be considered. I'm not sure if I have time to read through all the quotes, but I can just read the one on the right. This nurse participant said, "It was the first time that anything similar like this happened. Prior to the contest, if you had an idea, you go talk to your boss, who would go, 'Oh God, another thing I have to do when I have other things to do. How do I care about this?' But now it gives some empowerment that someone external is going to come in and say, 'Wow, that was a great idea, and we're going to help you to do it.'" So it seemed that offering the time and structure for staff to give input and acting on that input seemed to convey organizational support for learning, building on the context that we were aiming to study. And these findings should be considered in light of these limitations in mind. Our sample included just 1/3 of the cardiology unit, or just those that completed the learning organizational survey, so there could be some selection bias here. We also used self-reported survey data as our independent variable, which could be subject to social desirability biases. And our study was limited to a single unit in one organization, and conducting a similar study across units or across organizations would add generalizability, but also perhaps allow researchers to consider multi-level analyses. So next steps for this paper research is for us to analyze the content of the submitted ideas in terms of implementation complexity or feasibility, its impact and innovativeness, and relate these aspects as well as peer and managerial evaluations of ideas to dimensions of perceived learning. So thank you.
Thank you, Olivia. Any quick clarifying questions for Olivia?
Yeah.
Are you still in contact with the organization to see what is actually unfolded as they implement things and whether they continue this process?
I am. I found that we've been hearing that one challenge is with the implementation of these ideas, these healthcare frontline staff are so busy with patient care that they're having a hard time finding the time to implement these ideas. So apparently some physicians can apply for grants to work on projects and they can get paid for these time to work on this, but nurses or technicians are having a harder time finding, compensation for the time that they're using for implementation.
Thank you, Olivia.
Yeah.
You good?
Hi everyone, I'm really happy to be here today. Thank you for having me. My name is Michael Ann Kyle. I'm a PhD student at Harvard University and Harvard Business School, and I did this research project with two amazing collaborators and mentors. One of them is Sara, and the other one is Amelie Aveling, who's a research scientist at the Harvard HCM School of Public Health. So our study looks at the processes underlying team formation in primary care. And the reason for this is that team-based care has been promoted as central to transforming primary care. And primary care transformation is really viewed as one of the bedrock goals of improving quality and value and coordination in the healthcare system. So we have initiatives like the patient-centered medical home certification and pay-for-performance programs that try to incentivize team-based care and primary care transformation. But when we look at evaluations that have been done, and at this point there are quite a lot, we see consistently equivocal results. Either findings are null, or sometimes it works a little, or sometimes it doesn't work. And so the question really is why and what's going on here. From a management perspective, the theoretical context is that there's this extensive literature describing primary care transformation and team-based care, and yet we see this wide variation, even though at this point we've developed a lot of best practices. And so we have a lot of specific activities or guidance for practices in team formation, yet we don't see the uptake that we would expect. In terms of mechanisms, our hypothesis and what brought us to this study is that we think that the actual processes of change itself are affecting the resulting transformation or resulting teams. And so we are wondering, how do organizations pursuing the same transformation objectives achieve such different outcomes? So our goals were to explore variation in the extent to which practices exhibit characteristics of effective team-based care. And for this, we drew upon the literature because it's well described, and we thought about this in terms of patient-centered care, continuous capacity for continuous improvement, and staff satisfaction or prevention of burnout. We sought to identify and characterize the change processes that underpin this team formation process, and then we also sought to look at the relationship within these different elements of change. So our study setting was a multi-year primary care transformation initiative, a learning collaborative called the Academic Innovations Collaborative. It began with 18 academic primary care practices. There were hospital and community-based practices around Boston, and these ranged in size from about 30 to 40 staff to over 300. They included big academic medical center sites, and they included FQHC or smaller community sites. So there was a good amount of diversity in the type of setting. This was a multi-year study, and so we did it was a multi-year collaborative, and so we did our study at the end of year 3 and beginning of year 4. Our methods were that we sampled 12 of the 18 original members, and we did this using the Team Dynamics Survey, which was a tool developed as another part of this collaboration. And so each year, all practice staff were surveyed on a variety of metrics around their teamness and the extent to which they believe there was a functioning team in their practice. And so for a sense of the idea, so there was about 650 to 1,100 respondents per year in this survey. We conducted 48 semi-structured interviews with individuals in diverse roles across the practices: physicians, nurses, care coordinators, administrative assistants, medical assistants. project managers, and the idea was to get multiple perspectives on the experience of change in the practices. And so the 12 that we had sampled are based on the team dynamics, were the highest performing and the lowest performing, so that we could get some variation in how things were going. Our analysis we did using thematic networks. We used in vivo software, and we had a mix of a priori codes and emergent codes. We then, after doing our qualitative analysis, went back to the team dynamic survey data. At this point, we had 4 years, and we unblinded it and looked at the different constructs, not to the individual, but to the practice. So we could look at all the different constructs and responses within each practice to get a richer sense of what was going on in the teams, both over time and then within different domains of team formation. And so what we saw were in our qualitative analysis, were two large dimensions of change, functional change processes and cultural change processes. And so functional change speaks to formal changes in your job description or your responsibilities, organizational structures like formation of huddles or team meetings or QI meetings. And then cultural change processes will be like your change in your identity or sense of connection to your colleagues, or now you're a team member and what do you now owe the people that you work with? Or now that you have this quality improvement element of your work, now what does that mean for what you view as your job day to day? Within sort of the domains in the practice, there were two major elements. One was role revision, which we think of sort of as how we reorganized existing work. So say, you used to have a physician do a depression screening and now a medical assistant does it. And capacity building is what we think of as new work. So now you're going to have a team meeting. That's maybe something you didn't do before. And so what goes into that and who contributes? And so within these two major domains, we found that they contributed to effective team-based care. So within role revision, examples would be updating formal roles, clear task boundaries in your functional side. These were supported by cultural elements of sharing authority. Physician leadership was very important. So if the physicians were not on board with the change, this was a rate limiting factor. They were important in authorizing changes in the practice for other staff. Patient relationships had both cultural and functional elements, were very important. So in a team, if that gave more people in the practice the opportunity to form relationships with patients, this was incredibly nurturing to their professional development and their identities. In capacity building, we saw the clear communication pathways. So you would have maybe a huddle, a team meeting, a QI meeting. There's a way for information to flow up and down the practice. So people could, communicate upwards what they were experiencing and also receive clear direction. This also included new skill building, so learning how to do a PDSA. And the cultural element of this would be, a big one was willingness to experiment with the understanding that, as the earlier presenters mentioned, it's a very process-driven environment, so being okay, we'll try something new and it's okay that we're going to test it, and it's also okay if it doesn't work and we're willing to fail and try again. Use of data was also really big things, both culturally and functionally. So one, collecting data and then looking at it as a way to drive your work, but then also thinking now, okay, well, we want to do a new project. The first idea coming to head, okay, well, how do we measure it? How would we know if we were really succeeding or not? And then the elements of effective team-based care, which I mentioned. So then we did our qualitative analysis, we went back to the surveys, and when we broke out the constructs in a little more detail, we identified three typologies. So the high performers we characterized as practices who had high team scores or rising team scores across the 4 years. And we saw two different kinds of practices that we characterized as low performers. One group was low and they stayed low, or they dropped. And then another group just sort of cycled from year to year, 1 year very high, 1 year very low, without any clear direction. And when we overlaid this with our qualitative analysis, we came up with this interesting taxonomy, which is we found that the high-performing practices on the team scores had really committed to both cultural and functional change. So this means that they had invested the time to redo the roles and had invested the time to authorize their staff to take on new roles, for example. And in low performers, we saw two different types. One group, the ones who vacillated from year to year, they focused on cultural change and really neglected functional change. So they would come together and be inspired and see their colleagues in a new way, and then they just didn't have follow through. So things didn't get done, and then that would be discouraging. And then they would rally, and so they were kind of in this cycle. And then the other type of practice were the groups that focused only on function and not on culture. So they changed the roles and they changed the procedures, and they didn't change how people saw their role in the system. And they struggled. It was very painful, and either they didn't improve or they saw declines over time. So our implications for practice, one is that there's this recursive relationship between cultural and functional change processes. And so at the beginning, it might be easier to do one or the other, but over time that gets harder. And you'll start to struggle. But if you prioritize both at the beginning, you may feel like you're not really getting off the ground, but over time it became easier. With respect to theory, we tried to elaborate these change processes in detail and the interdependent relationships among the transformation activities. So there's a lot of the things that we've described here have been described before, but really showing that culture and function are really irreducible, and you shouldn't separate them, and that they support and build upon each other in very specific ways. And then we describe this taxonomy of practice change types that really came out very beautifully in our data. And then with respect to policy, there's significant heterogeneity in implementing a transformation program. So one thing to think about is that the existing criteria for assessing practice transformation relies very heavily on functional measures. Did you complete the PCMH application? But it really may not accurately be assessing whether the practice has transformed. Have they really formed teams? Are the teams really working, or do they just exist on paper? Our study has a number of limitations. So first of all, it's qualitative, and so it's not causal. We have a very diverse and interesting practice sample, but again, may not be generalizable. And we relied a lot on self-reported data, both in the interviews and in the team surveys. This was based on how people perceived their role in the practice. And with that, I thank you.
Thanks very much. Clarifying questions for Michael Ann? Very clear. Thank you.
Do I want to do this? Oh, Jesus. Oh, gosh. What is that? I don't know what all these fonts are. Okay, here we go. Okay, we're in business. Okay, good morning, and thank you for being here. I'm so excited to have this opportunity to share some work that we completed relatively recently, looking at strategies amongst primary care practices to improve care for complex high-need patients in the context of a statewide pay-for-value program. And I'd just like to reiterate, I think these 4 sessions go together really nicely, and some of the things I say, especially in setting up my work, Michael Ann already said, and probably better than I will, so thank you all for that. I want to just start by acknowledging this project was supported financially by the Commonwealth Fund, and I want to mention my stellar group of co-authors here. So Julia Adler-Milstein and Christy Lamack were the co-principal investigators on this broader project, and then Jenna Cohen, Ariel Linden, and Paige Nong. Okay, so this piece of the project was motivated by a few key observations. So, with the proliferation of all of these policy initiatives going on to try to improve the quality of primary care, and you can pick your favorite flavor. We have medical homes or medical neighborhoods. We have pay-for-value programs, changing interorganizational relationships and affiliations. And as Michael Ann mentioned, when we look at evaluations of these various initiatives, we see really mixed evidence. So overall, a marginal net significance, a lot of kind of mixed results. And we think that those kind of marginal net overall results might be masking some underlying variation in terms of specific organizations that might actually be making significant improvements. And the focus of this study is maybe for specific patients, they are in fact moving the dot on quality and quality of care. And so the group of patients that we really are focused in on are what we're calling complex high-need patients. So these are patients often with multiple chronic conditions that have serious clinical healthcare needs and also a lot of social needs as well. These patients have higher than average utilization, often experience lower quality, and as I mentioned, have this kind of distinct extra set of healthcare needs to really round out their primary care experience. And so as practices are grappling with this large and growing segment of their population, they're really kind of seeking out, looking for strategies to adequately care for this population. And specifically, there are a couple of key challenges in the way here. So one is kind of a parallel workflow problem. So how do you balance the needs of this complex patient population simultaneously with your relatively more healthy population, needing different services, different lengths of visit time, things like that. And then also, the body of evidence about what works with respect to complex high needs patients is not all that robust. So in the face of kind of limited knowledge about best practices or what we should, what works best, where do you go? What do you do? And so we kind of looked within 3 strategic domains that we thought might shed some insight or some light on what practices might be able to do to kind of deal with this uncertainty and move forward in trying to improve care for this patient population. The first, which I will try to focus on since it's the focus of this session, is about organizational learning. And we kind of characterize this in 2 key ways. So one was external learning, or the idea of trying to bring outside knowledge into the walls of the practice. So rather than kind of operating on their own little island, to what extent did practice leadership, practice staff go out and seek information, new ideas, new strategies, new lessons learned to bring back into their practice? Also internal learning, and this had to do with how ideas were brought forth or shared within the care team. So really focusing on communication within a healthcare team and within the whole practice. We also looked at motivation within practices. So this had to do with how practice leadership, what practice leadership really valued in the organization, and then consequently what they rewarded amongst practice staff, and how they motivated individuals towards those goals or ideals. And that could be both in terms of financial or non-financial incentives. And then finally, a little bit more self-explanatory is the acquisition and use of resources. So this has to do with the people, the technology, the services, how are practices accessing and deploying the stuff that they need to get things done for this population. So the aims for our project were twofold. So one, we wanted to identify specific strategies amongst primary care practices within these 3 domains of learning, organization, and resources that were actively being used to improve high-need patient care. And then second, we really wanted to think about what strategies were differentiating practices that had been able to demonstrate meaningful improvement in care versus those that did not, with the idea that in terms of policy and practice implications and recommendations, the strategies that are being pursued by the improving practices kind of have a little bit more evidence behind them that, these might be particularly more effective strategies. So in order to do that, we first had to stratify and then recruit and interview practices that we deemed both improving and non-improving with respect to delivering high-need patient care. And I don't want to dive too far into this, but just to set up some context here, so this study took place in the state of Michigan. We're looking at primary care practices contracted with Blue Cross Blue Shield of Michigan, which is the dominant commercial insurer in the state. We were looking specifically at patients in these practices with at least one chronic condition, often more than one. And for our analyses, they had to have at least 30 on their patient panel, again, often more. The pay for value context here is called the Physician Group Incentive Program, or PGIP, which I'll refer to quite a bit. This is a widespread pay for value program in the state. It was started over a decade ago, really widespread participation, numerous quality improvement pay for value arms to this project. And the time frame I'm looking at is 2010 to 2013. So what we did, this is a kind of rudimentary graphic here, but so we were interested in practices participating in PGIP. Again, we're kind of interested in this pay for value context. How do you kind of motivate and enact change that improves high need patient care within this existing incentive framework? So to determine improving versus non-improving practices, we first used a propensity score to match each of these practices to a non-PGIP participating practice in the state. We did that based on demographics and baseline year outcome measures. And then for each of those practices, we calculated the trend of 10 different outcome measures, and we compared those trends to the matched control. And what we said was if a practice did better than their matched control on at least 7 of our 10 measures, they're going to be considered an improving practice. And if they performed better than their matched control on 4 or fewer, we're going to consider those practices non-improving. And here's a kind of flavor of what our outcome measures looked like. So we had cost, utilization, and quality measures. So we conducted a total of 14 practice interviews across the state. These were done in 60 to 90-minute semi-structured interviews. And the interviews were conducted double blind. So the interview team that went out to the practices did not know whether it was an improving or non-improving practice. And the practices themselves, although they asked us what category we considered them in, was not told what category they themselves were in. Verbatim notes were taken during these interviews, which were then coded with an initial set of kind of broad themes, which the team then broke down and kind of iteratively refined more specific strategies within those three domains of learning, motivation, and resources. And then we used weighty comparative data tables to kind of weigh the evidence for each practice and assign who was doing what. And this was all done while the data was still blinded, and we didn't look at who was improving and non-improving until all of this analytic work had been completed. So here's what we found. So we interviewed 31 total respondents across the 14 practices. We had a nice mix of physicians, care managers, practice managers, nurses, and techs. And we identified a total of 11 strategies across our 3 domains of interest. And I'm going to go ahead and walk through within those 3 domains what we found. So I'm going to start off with our learning strategies. So the first was participation in external learning collaboratives. And this involved, for the practice managers, often monthly practice manager meetings. For physicians, there were often meetings held at the hospital or the regional physician organization. And this was, again, an example of kind of stepping outside the walls of their own organization and hearing what was happening elsewhere. What were other people struggling with? What were other people trying out? And bringing those ideas back into their own practice. The other type of external learning that we saw was active utilization of payer websites. So, in some of our non-improving practices, we heard, well, we know we do a good job. We deliver great primary care. And while that is great, we saw more often in our improving practices this desire to look for this kind of outside source of information to see what are we doing well, but also what can we be doing better? Where are our gaps in utilization and care quality, and how can we bring that information in and change what we do? And you can see in the quote again, some of these practices were really proactive about searching this information and incorporating it into their patient care visits. What we found as a third learning strategy that we found non-differentiating between our improving and our non-improving practices was the internal learning part. So although this didn't look identical practice to practice, we saw no meaningful differences between the improving and non-improving practices in terms of internal communication practices or strategies. So whether it was utilizing the EHR communication tools, team huddles, staff meetings, those things were present on both sides of the table. In terms of motivation, so one of the key things that we found here that seemed to differentiate our improving from our non-improving practices was how participation in PGIP was framed. So these are direct financial incentives, and as I'll talk about in a minute, staff roles and responsibilities changed in response to these incentives. If you're going to say that you're going to pay us to make phone calls after a patient is discharged from the hospital, we're going to do that because we want that money. But in our improving practices, we more often saw a commitment by practice leadership to talk about this as an opportunity to fundamentally change how they saw the delivery of primary care and what it meant to deliver good, comprehensive primary care. And you can see in this quote, again, it's, well, we now consider ourselves as a practice differently. We put the patient first. We're thinking more critically about how we deliver care and what we think is best. Another thing had to do with how those external incentives were distributed within the practice. So in non-improving practices, we more often saw that money coming in the door and going right to the physicians. In our improving practices, we more often saw that money, as you see in this quote, going to every member of the care team. Practices saying every single person who touches the patient played a role in that patient's care, and so everyone gets a piece of the pie. Or investing in practice resources that could continue to be used to improve the quality of care delivery. Our non-differentiating strategies was what I mentioned before, so kind of the direct change in staff responsibilities as a result of the PGIP incentive structures. And then this was non-differentiating in the respect that nobody was really doing it, was use of non-financial incentives. We kind of probed on that, and there didn't seem to be a lot of activity in that area. Last, we have our resources. So a big one here was employment of a care manager. Almost all of our improving practices had employed a care manager. And I think this quote really captures the idea to which a care manager kind of expands the bandwidth, expands the capacity for delivering services outside of a typical clinical visit. So the MAs are busy, they're running around doing other things. The care manager has the time to sit down and talk about social support, to talk about strategies for medication adherence, and really became a critical member of the care team. The other idea was taking this administratively burdensome and intensive PGIP participation and utilizing their physician organization or their affiliation with the hospital to kind of offload some of that administrative burden and focus more on the clinical care delivery that they were more expert in, and kind of using those that external expertise to, again, kind of expand their bandwidth, put that with the physician organization, and focus on clinical care. Our non-differentiating strategies here, again, not that this looked identical across practices, but that there weren't meaningful differences between the improvers and the non-improvers, was use of EHR and then leveraging available community-based social services, so Meals on Wheels and things like that. Almost all practices had those resources available. So I am out of time, so I'm going to rush through this a little bit. So here's kind of the key results all in one place, our 6 differentiating strategies. And we really kind of have 3 higher level concepts that come out of those strategies. With the idea that moving forward, thinking about incentive programs, thinking about suggesting best practices to primary care practices leadership, that these strategies really highlight three things for us. So one, this importance of bringing new knowledge into the practice and having a practice culture that's kind of open to these new ideas and flexible to changing in the face of, delivering care for a subpopulation where we don't really know what the best thing is for them at this point. The ability to foster intrinsic motivation, so not just a direct response to external financial incentives, but using this as a window of opportunity to kind of change, again, practice culture, how care teams work together. And then prioritizing resources that really serve as capacity expanding strategies. And I will stop there since I am out of time, but happy to talk more after.
Thank you, Dori.
Thank you. Oops, sorry.
Hi everyone. It was a pleasure to read these papers and hear these presentations and be able to sit with them a little bit. And what I'm hoping to do is give you an overview of some of the themes that I think all of these papers bring together and highlight in a way that I think is important in moving the conversation forward. And that conversation I saw as, well, our focus now is patient experience and patient outcomes. And I think all of the talks that we heard today really shared that as a theme. But what I thought was really interesting is that they did this at different levels of analysis. So we heard with Dori about payments and the importance of thinking about the industry level changes. Across both Yuna and Dori and Michael Ann's presentation, there was this sense of PCMH work. At the team level, really with Yuna and with Michael Ann, we started to understand some of those processes that were really driving some of the changes. And at the individual level, also with Yuna and Olivia, we started understanding some of the characteristics of the individuals of the voice. And I think one of the things that was really exciting about these papers was the fact that they really challenged this idea of if you put it in place, it'll work. Because they showed that you can put these features in place and half the time they'll work and half the time they won't. They'll be just as good ideas and they won't be implemented. So I think that allows us to dive deeper than if you create it, it will just work out. And I think it gets us to this conversation about process. What is going on? What are some of these micro features that help us move from the building pay for value to actually delivering better care? And so I am going to take the liberty, because I am a visual thinker, of laying out how I saw these four papers knitting into the ongoing conversation in our field of how we're going to use some of these process findings to get to better patient outcomes and better patient experience. So I'm going to start with Yuna. And I think this measure of creativity and as a measure of usefulness and novelty is really important, because oftentimes we either think of one or the other. And I think it's at that intersection where a lot of the ideas become very powerful. And then the impetus of this is often, and I'm not sure if you've noticed this theme, of bottom up instead of top down. So where a lot of the ideas are coming from the frontline staff as people who experience this. But what was interesting, it was that I read in Yuna's paper was walk the walk instead of just talking the talk. Yes, of course we know frontline employees are a source of ideas, but what happens when they actually generate those ideas, and can we trace that path all the way down to better patient care? What she did by showing us a couple of levels of analysis. I thought the change maker characteristics was so powerful that tenure and centrality were critical to being able to do implementation, and yet roles weren't. So it wasn't the physicians, it could be the medical assistants if they had these characteristics. So it helped us kind of think outside of roles. And with implementation, she did a beautiful link to how this created better patient outcomes. And one of the things that I think resonated both in her work and Michael Ann's work was that if these creative ideas were done by individuals, they were much less likely to be implemented than when they were collaborative, when they were done in a group work. And I think Michael Ann's paper starts unpacking some of those processes for us, where she talks about this cycle of function and cultural. And the one thing that I think really stood out for me, and I imagine might have stood out for you, was this idea that all of a sudden you have a team identity that shifts. And that shifts allows for people to not just envision themselves as physicians or as givers of information or of medical assistants, as receivers of information, but really as a team identity. So then you can provide feedback and challenge each other. And that's what allows for some of that change in autonomy that became so important for the shifts that she saw in hierarchy. And that legitimacy is becoming a theme. And so to briefly touch on the antecedents of voice, we also saw external resources such as the Learning Collaborative and how that lowered the barriers that many of these practices experience. And the barriers were sometimes around training, sometimes around financial. But then we started to see external legitimacy in Olivia's paper through this contest. What happens when the barriers are so high that this group work becomes really difficult? Let's think about this external shock about this contest. You bring these experts in from Harvard Business School, from other places, and create a legitimate contest that allows people who might not have otherwise have shared ideas to share ideas. And that medical assistance idea now becomes legitimate, and it becomes a catalyst for other ideas in a way that kind of kickstarts the process. And then when we think about Dori's work on pay for performance, that is also changing the legitimacy, but at an industry level. And it starts creating shared resources again at an industry level. And it provides these internal resources and legitimacy, what she was talking about in terms of reinvesting in the practice and creating more equality by showing how that reinvestment happens and lowering kind of that hierarchy over time. So this was my quick synopsis of how I think these papers really kind of further our conversation. And I think one of the words that kept coming up, and I think as we talk more about organizational learning in your questions, this idea of legitimacy as being really critical to allowing some of these change processes to happen.
Okay. Thank you, Pat. That was fantastic. I'm gonna suggest, why don't you guys come up, because since they're filming, that way they'll see your responses. We have a few minutes for questions. I wonder if folks have some. As they get seated, I wanted to, I'll start since I don't see hands. I wonder if in your investigations, building on what Pat was suggesting, you could give us a sense from the conversations that you had with the subjects that you were speaking with. What is the current sense of frustration, level of frustration, and are the functional, cultural, and legitimacy enhancing efforts that we are employing, are they enough to get people willing to invest again in these learning-oriented kinds of behaviors, or are they so burnt out and so frustrated by the environment that we have much more to go? What's your sense? I think it touches on a lot of your research.
Who wants to go first? Okay, I'll kick off, Sarah. I think I was so inspired by all of the talks here, and in terms of making me think about my own work, qualitatively, what I found in a lot of these discussions with the frontline staff in the organizations that I worked with was there was simultaneously this desire to change and to improve, but also this acknowledgement that healthcare workers just have so many pressures, so many demands. They're also a little bit, there is this fatigue of quality improvement at the same time, so there's this desire for change, at the same time acknowledging the realities of the work that they're facing every day. So I think that in my case, I saw that carving out this sort of formalized structure for ideation to occur and for quality improvement to exist in sort of a protected form was one way to think about having improvement occur at the same time as healthcare work every day, and all the things that you have to do for patient care at the same time. So thinking of ways that we can simultaneously continue to do the work that we need to do, but also improve at the same time.
I think it's a great question, Sarah. I think that change fatigue and burnout was very high, and even people who were very committed were exhausted. And we really found that in our high-performing practices, that was like the most protective environment, because when people were tired, there was now this relationship to say to someone else on their team, like, I am exhausted, and so they could pick up another leader, either motivationally or I will do this report for you. And I think that mutual support was like essential to getting different people over humps at different times.
One thing that really stuck out to me in my interviews with the staff that participated in the contest was that there was no outlet before this contest. It was really amazing that prior to this contest, that there's no outlet for the frontline staff to share their ideas, even though they're the ones that are walking the walk. So actually, the contest in the Heart Center was done in 2014, and just this past summer, they did another contest within the Cancer Center. So it seems like their interest is building within their larger organization to have this kind of organizational intervention to encourage frontline staff to speak up. And I think another important thing is, in addition to getting these ideas spoken up, is to acting on these ideas, to show that these ideas are being heard and valued. I think that could also act on fatigue and burnout as well, that it could be used as like something to energize and something that could be refreshing, this type of contest, and acting on it, like giving out t-shirts, like giving out iPads, going online and sharing ideas. It could also energize and refresh staff in their work as well.
And I'll just briefly chime in here. In the Michigan primary care context under this Pay for Value program, a lot of frustration, a lot of fatigue. This program has been going on since 2005. And a lot of practices saying we're just so frustrated. You know, we look at our measures and it doesn't really, you know, we really do think we're doing a good job, and these measures are not capturing what we think of as our true practice strengths and what we're doing for our patients. And so I think that's where the external learning piece came into this a lot, was finding a sympathetic ear. So these practice managers and these physicians going out to these kind of community-wide meetings and hearing the same thing from other practices, and thinking about ways, in some respect, that they can still meet the PGIP program requirements, but continue to move forward on all of these other initiatives and strategies that they think are making a difference in patient care, even though they're not explicitly being included in the Pay for Value programming. You know, and some whispers of trying to actually talk to Blue Cross and think about how to incorporate what they think matters that's not in PGIP, trying to get that into PGIP. But I think that channel for communication was not quite as open as they had hoped it would be.
Thank you for giving voice to that frustration. I wanted to bring it back to a slightly more hopeful note, which for this group, which is to say that I think that there is an urgency around health organizations' efforts to deal with their implementation challenges and strategies for encouraging follow-through and sustaining their ability to implement change. So they're looking to us now, increasingly so, to bring to them solutions and strategies from the management sciences to help them solve these problems. So I saw some hands in the audience. John, do you have a question?
Yeah. So I wanted to just differentiate a little bit in this functional and cultural elements, that there maybe a third element that's sitting in there, was touched on a few times, and that is power. And you talked a little bit about sharing authority. You talked a little bit about the use of data as another form of, of authority, if you like, or power. And the legitimacy is also brings up the question of who has power to grant legitimacy? You know, where does that lie? So I think, you know, I want to try to add in and see what your thoughts are on this, that maybe you need three elements. You need the functional, the cultural, but you also need the power piece.
Sure. I'll hop in. So I think that's absolutely the case. And maybe it would make sense to pull it out, but it was completely woven into both of them, which is that if we didn't see the people in power, and specifically the physicians, agree to a change, it was very hard to make it happen. Mm-hmm. And so I think that's an essential piece of it. And there's the data was actually very interesting that you mentioned that, because that was a very democratizing element. Because before, you know, the physician always has the chart, and now everyone can look at the chart, and so other people can take initiative. And then suddenly the physician finds out, oh, okay, well, someone else made the calls already. And as you start to see, you know, when you give up a little bit of power, that your life gets a little easier, it creates a positive dynamic. But yeah, it was completely woven into everything.
Thank you. Other questions from the group? Do you guys have questions for each other?
I actually have a question for Yuna. I was really curious about the finding you had, the negative relationship between the creative ideas and implementation. Mm-hmm. So I was wondering if you got to see maybe the feasibility of the ideas. I was just wondering if the more creative an idea is, the maybe less feasible an idea might be, mm-hmm. and maybe that could contribute mm-hmm. to limited implementation. I don't know if you had any thoughts on that.
That's a great comment, Olivia. I think the nature of how we measured creativity, so splitting that out into novelty and usefulness, I think attends to some of those concerns. But qualitatively, when we were reading the meeting minutes and really understanding what was going on in these meetings, it's absolutely true that there was some sort of skittishness about the high creativity ideas. I think that particularly at the beginning of the 18 months, there was this sense if a potentially risky idea that has unknown effectiveness comes out, you're just not sure what to do with it. There was sort of a gradual accumulation that occurred during the 18 months where there would be more of a patience to see, maybe let's just follow this trail and see what happens with these kind of ideas and see how they form, with the acknowledgement that maybe they will fail, maybe they'll be effective, we're not sure. But certainly at the beginning we found that, particularly when these teams were initially formed, that the ideas that were getting implemented were the sort of low-hanging fruit, the higher usefulness ideas, the lower novelty ideas that weren't really rocking the boat so much. But over time, as the teams got to know each other, that was when they started to really discuss and really grapple with these higher creativity ideas that required a little bit more engagement. So that's it, yeah.
Great. Well, thank you very much. I think we'll leave it at that. We're just about at the end of time. Thank you to our panelists. Thank you to our discussant. Thank you for being here this morning.
Keeping such a tight track of time.
I would love to.